So with the digestive system, this works from the top to the bottom of the system, just like all of the rest of the body systems that we've covered do. So first thing first, as always, you should go through and underline the different sections of the body or different body systems. So we start with the lips, underline the vestibule of the mouth. There's not much else there to begin the digestive system. Let me flip this over. Okay, so on the next page we have the tongue and the floor of the mouth. And again, my little notes in here just to remind you guys that this starts from the top and goes down to the bottom. So it's going to start at the lips and go all the way down to the anus. It actually starts at the lips, goes through the anus, all the way down to the anus, and then ends with the accessory organs of the digestive system and any of the abdominal omentum. So you should know, for instance, that like the esophagus codes will be closer to the top because it's closer to the top of the body system. A couple of things to note here on page 178 is that dental has their own codes and their own coding manual, so there aren't very many dental codes in our coding system, but these are some of the codes here that you may see on the medical side. So these dental alveolar structures, 41800 down to 41806, you may see those on our side if there was an oral surgery that required the use of those. So on the next page, again, underline your body systems. Let me see, I don't have too much starred there. Something you should note there, though, that codes 42200 and 42205, you should bracket those. These codes will only be used if they are both present. So if you're going to use those codes, you have to have both of those. So there needs to be a palatoplasty for cleft palate, soft and or hard palate only, and then with the closure of an alveolar ridge or soft tissue only. So if you're going to use one, you have to use the other. And these, I just made a little note over here, are your cleft palate and cleft lip codes. So we move on down through the salivary glands and their ducts, on over to page 180, where we have the pharynx, adenoids, and tonsils. And a couple of things you should note here. For codes 42820 all the way down to 42836, you cannot use the 50 modifier for that. Even though there may be two adenoids, we don't use the modifiers for those. Also, those happen to be very commonly used codes because they are tonsillectomy and adenoidectomy codes, and we have lots of kids that get their tonsils and adenoids out. So over to page 181. A couple of notes here. Again, you want to underline your body structure, which on this page is the esophagus. But then I would like to also let you know that under other procedures, 42955 all the way down to 42972, 42999 is not included in this bracket. So those codes there, 42955 down to 42972, may need the 78 modifier. And so what that 78 modifier is that the 78 may be there may be a complication of surgery. So what's going to happen is the patient's going to go back into the operating room unplanned. So if they came out and realized that there was a complication of bleeding, something didn't get cauterized the way that it was supposed to be, then they had to go back in to the operating room and cauterize that vessel to stop bleeding. Then we would use a 78 modifier on there to show that there was a complication of the surgery and that they were presented to the operating room, although it was unplanned at the time. Okay, so over to page 182. A couple of things here. We're going to start with endoscopy. And the endoscopy is always going to include the dilation of the esophagus if it's done. It's not always done, but if it is done, then the endoscopy codes will cover that. So we don't want to unbundle those. And so talking about, first of all, endoscopy, I just put a little note here that it's actually the endoscopy of the esophagus. And then my little sticky here, that dilation is a separate procedure, but it's going to be bundled in with these endoscopy codes again if it's present. So if it's not, then we don't worry about it. We don't add it in there. But if it's there, then it'll be bundled. Other than that, I don't have anything else to know on 182 or 183. Whoops, sorry. I dropped my phone. 184. we have a couple of things here. The esophagogastroduodenoscopy is also abbreviated as an EGD. And that basically is going to go down from the throat. It goes from the throat down through the esophagus and then down through the stomach, which is where the duodenal part comes from, the gastro and duodenal part. The duodenal part actually comes from the small intestine. So the duodenum is part of your small intestine. So it's going to go from the throat down through the esophagus, through the stomach, and into the small intestine. So that's where that big long word comes from. Those are all the body parts that the scope's going to go through. Not much else there. For page 185, a couple of notes here. Up at the top, 43246, I put a note in there that that's a PEG tube. And you want to, it just helps kind of pick it out. If you see that in an op report, a PEG tube, then that would be the code we would use for that. Something else I want you to pay attention to on this page, there are lots of sideways arrows. And you need to check, that means you need to check these codes and read these codes very carefully, because that means that these codes have been revised from previous editions. So there's been a lot of revisions in this particular section of the manual, so you want to be mindful of that. Oh, flipped one too many pages. Okay, so over on page 186, I would like for you to underline the first letter in each of the following words for endoscopic retrograde cholangiopancreatography. That makes up the abbreviation ERCP. And so what they're doing when they do this procedure is that they're injecting dye, and then they look at the blood vessels, the biliary tree, if that's what they're going for. Basically, it looks for gallstones, and if they're going to look for gallstones in the biliary tree, then they'll inject this dye and do this procedure to check for them. Okay, on page 187, I don't have any extra notes for you there, but again, I would like for you to pay attention to the fact that there are all these sideways arrows, because that means that these codes are revisions from the 2014 edition. Page 188, you must pay attention to the approach when you're coding for gastrology. So laparo means abdomen, and scope means visually looking in. So when you're looking at the laparoscopy, we need to know that you need to remember that this is not an open approach. So basically, they're going to go through the belly button with these laparoscopies, and I know you've seen these in every other body system, but they're really important in gastro. So they're going to go through the belly button, insert a long metal trocar is what it's called, with a camera inside of it, and then they're going to pump you up with CO2, and then that helps them visualize what they need to see better. So these are not open procedures. If it's an open procedure, then it would be something where they would make an excision and then retract the skin and tissue open so that they can see. These are not open. They're just putting a scope in and looking around. Okay, over on page 189, again, we're going to go through manipulations here, and these are with endoscopy only. So you need to be aware of that. I would probably write that down there. That code 4350 is manipulation with endoscopy only, and that is the dilation of the esophagus by unguided sound, or, I can't read that very well, bogey, or single or multiple passes. So just note there that that's with, if they do a manipulation with the endoscopy only. Okay, the next page we're going to go through that starts the stomach codes. So you want to make sure you note your body system up there, underline stomach. We go through incision and excisions, and then we start with laparoscopies of the stomach. A couple of things down here under the introduction that you should be aware of. It says naso or orogastric tube. Those are NG tubes, and you most commonly will see them as NG tubes. So you want to make sure that you are aware that those are the NG tubes. So you only want to code this if the physician placed the tube, because if the hospital placed the tube, it's the same thing as it was before when we were talking about those stress tests. If the hospital placed the tube, then the hospital is going to bill for that. So you're only going to use these NG codes if the physician that you're working for placed the tube in the patient. So if it was done by the nurse or in the hospital, it's going to fall under hospital billing. So I just made myself a little note there for that here. Okay, 191 starts with bariatric surgery. I just made a little arrow because even though it's not a body system, it does start a new procedure group. And that's about all I have for that. Page 192, I just underlined intestines. Please note that it also says except rectum, and that's because the rectum is included in another part. So make sure that when you're looking, even though the rectum is technically connected to the intestines, this is not where you will find the codes for rectal procedures. If you go over to page 193, we start with the excision codes of the intestines. Again, we're still talking about the intestines. You have excisions. A couple of things that you should note. Code 44120 is an enterectomy, resection of the small intestine, single resection, and anastomosis. And so I think I told you guys this before, but I put another note in here just because sometimes I need reminding myself. The anastomosis means that they take a section of the intestines out, and then they stick the two remaining ends together. So if you think of a Twizzler, if you cut the middle of the Twizzler out and then fuse the other two remaining parts of the Twizzler together, then you will have a shorter Twizzler, but you will have an anastomosis of the Twizzler. That's probably a really gross depiction. So it comes in segments is basically what it is. They're fusing segments together. Okay, those are all the notes I have for that section, or that page. We go over to page 194 where we start laparoscopies of the intestines. And so here, one little note up here, this is the only one I have on this page, is that you want to make sure you know if it's small or large intestine that you're coding, because that's going to make a difference in your code set. Excuse me, your code selection, not your code set. So that's all we have on that page.